So coming to rheumatic fever. So what is acute rheumatic fever? It's an autoimmune disease caused by molecular mimicry, where it's a non-suppurative, non-inflammatory response to gas infection. That is group A streptococcus infection, typically Streptococcus pyogenes. What is rheumatic heart disease though? It's a chronic progressive valvular damage due to recurrent acute rheumatic fever. Remember, recurrent acute rheumatic fever may be clinical or even subclinical in nature. So patient may or may not be aware about the development of acute rheumatic fever. And some patients, they don't even know that they have got a sore throat and recurrent acute rheumatic fever. Because of subclinical carditis, they might end up with rheumatic heart disease, and they may present at that point of time also. Epidemiology-wise, it's common in female children, especially in the age group of 5 to 15 years. And global burden-wise, it's a leading cause of acquired heart disease in children in developing countries. The most important risk factors are going to be overcrowding, poor access to healthcare, and untreated streptococcal pharyngitis. As a part of primary prophylaxis, if you're giving antibiotics like penicillin within 9 days of onset of pharyngitis, you can probably prevent the development of acute rheumatic fever. That's what your guidelines say. Clinically, they're going to present with arthritis, the most common feature and the earliest feature. It's going to be migratory, asymmetric, polyarticular, large joint predominant arthritis. And all three layers of the heart are involved in carditis, like your myocardium, endocardium, and pericardium. And if you look at the most common structure that is involved in the heart, it's the heart valve, and valvulitis is so common. And among the valve, the mitral valve is the most commonly involved, and patients can have Carey-Crumb's murmur, which is a mid-diastolic murmur due to mitral valvulitis occurring in acute rheumatic fever. And patients can develop MR murmur also, and MR is one of the most common lesions in patients with acute rheumatic fever. In MS, it's rheumatic heart disease. In MR, in rheumatic fever, it is MR. Patients can develop pseudonym chorea, which is something that's going to present with a long latency period, where children especially can present with involuntary jerky movements, which is going to worsen with movement, and it can disappear completely in sleep. And I think in neurology would have studied about the features of pseudonym chorea, and don't forget that jack-in-the-box tongue, pronator sign, and all those, and milkmaid grip, and all those. And patients are supposed to have hypotonia as well, along with chorea. And patients can have erythema marginatum, which is nothing but a pink serpentinous rash with central clearing, which never occurs in the face. And patients can develop subcutaneous nodules, which generally tend to occur over the extensor surfaces, which are painless and often associated with severe carditis. Okay, so this is the Jones criteria, right? We have talked about the major criteria already. So we're going to have carditis, polyarthritis, erythema, chorea, erythema marginatum, and subcutaneous nodules. And we have the minor criteria like fever, arthralgia, which can be mono or polyarthralgia, elevated ESR and or CRP, and prolonged PR interval. So there should be evidence of gas infection to apply Jones criteria in the first place, which can be obtained in the form of throat culture or rapid antigen detection test or elevated ASO or anti-DNS P titers. And diagnosis can be made with the help of two major criteria in the evidence of gas infection, or one major and two minor criteria is also fine. In case if you're diagnosing recurrent acute rheumatic fever, just three minor criteria itself is enough. So two major, one major, two minor, or even three minor criteria is enough to make a diagnosis of acute rheumatic fever if it's a recurrent case. So plus, as I said, Jones criteria will not be applicable without evidence of prior gas infection. So that is a must to be proven. So what is the modification in high prevalence areas? So monoarthralgia or monoarthritis is acceptable. So especially in high prevalence areas, even monoarthritis can be taken as a major criteria, and monoarthralgia also can be taken as a minor criteria in high prevalence areas. So fever, usually it is more than 38.5 degrees Celsius, but in high prevalence areas, more than 38 degrees Celsius itself is enough. And ESR usually is supposed to be more than 60 millimeters per hour in low risk areas, but in high prevalence areas, ESR more than 30 millimeters per hour itself is acceptable. So these are some modifications that's done for the high prevalence areas. The thresholds will become lower because the incidence is very high. So you have to pick up more cases. So management wise, first infection control. So you're going to give benzathine penicillin IM 1 dose or oral penicillin B, and you can give aspirin or NSH, which is the mainstay, and steroids can be tried if it's a severe carditis. And for severe chorea, mild chorea can be managed supportively, but if severe chorea, you can try valproate or carbamazepine. And if it's a refractory chorea, then you can try corticosteroids or even intravenous immunoglobulin. For heart failure, treatment is symptomatic, like you're going to give ACE inhibitors, diuretics, and so on. And in case if it's a severe carditis, probably you can add corticosteroids. What about the secondary prophylaxis? So secondary prophylaxis include benzathine penicillin. So this is the drug of choice for secondary prophylaxis, and you're going to give every 3 to 4 weeks. So remember, for primary prophylaxis, you're going to give at least for 10 days, one dose for 10 days, or oral penicillin V for 10 days. And remember, if you're going to give any penicillin drug within 9 days of pharyngitis, within 9 days of streptococcal pharyngitis or streptococcal infection, you can actually possibly prevent the development of acute rheumatic fever. Possibly you can prevent the development of acute rheumatic fever. Possibly you can prevent the development of acute rheumatic fever if you give within 9 days. Within 9 days of onset of pharyngitis, if you give antibiotics like penicillin, which can be benzathine penicillin or oral penicillin or even amoxicillin, you can probably prevent the development of acute rheumatic fever. That is the rationale for primary prophylaxis. But for secondary prophylaxis, you're going to give benzathine penicillin G IM 0.6 to 1.2 million units based on the body weight every 3 to 4 weeks. And ideally, I would suggest giving every 3 weeks in high prevalence countries like India. And penicillin V is acceptable alternative, but it's inferior to IM injections. In patients who do not want injections, you can try oral penicillin V. So we're going to give 2 times a day. Typically, the dose will be 250 milligram 2 times a day. And sulfadiazine can be tried as once daily dose, which is an alternative to patients who are having penicillin allergy especially. So the dose will be 1 gram per day. And you can try a macrolide antibiotic like azithromycin 500 milligrams once a day for patients who are having sulfur allergy as well. So, but this is not an acceptable alternative because of the high rates of resistance in a lot of areas. And what's the duration of prophylaxis? If the patient is having carditis, then you have to give at least for 10 years or until the age of 40, whichever is late. In case if it's severe valve damage, some societies say that you need a lifelong prophylaxis as well. If it's a severe valve damage, you might require even a lifelong prophylaxis. And if the patient is having only carditis without any other residual heart disease or valvulitis, then the duration will be for 10 years or until the age of 21, whichever is longer. And if the patient is having acute rheumatic fever with only arthritis but no carditis, then in that case, you can give for 5 years or till the age of 21, whichever is longer.